Merci, Hervé. Bonjour, Madame et Messieurs. Je suis Yossi Cohen, and I'm afraid I will have to revert to English from now on. This is all my vocabulary in French, I'm afraid. But my colleague Stern kindly will translate. So thank you very much, Stern. Merci beaucoup. So I am working for the NHS. The NHS is the National Health Service in the UK. That's the government provider for healthcare for the residents of the UK, primary and secondary care. And I also work for INTERSYSTEMS as a clinical advisor. So, and I'm going to tell you the story of Coordinate My Care. Sometimes we abbreviate it to CMC. So when you hear me say CMC, this is Coordinate My Care, which is actually an NHS service that was started in a big cancer hospital in London called the Royal Marsden. And as working for both the NHS and INTERSYSTEMS, I think I have perspective of this project from both sides. From the side of the clinician who needs to treat a patient. I work in acute hospital as a doctor, and also from the side of a supplier that tries to build a system to satisfy that need. Would you mind passing me the clicker? Thank you. So first I want to give you some context. You can't see, I'm sorry. So I want to give you some context with regards to the requirement or the need in the UK. So in the UK we have every year about more than 500,000 that die. And for about 2/3 of them, this is an expected death in the sense that these are people in the last few months of their life, that everybody knows that they are dying, they know that they are dying, and they need specialist care to help them die a dignified death. Majority of these people would like to die at home because they know that hospitals cannot offer much more for them, but regardless, most of them die at hospital. And even when they do die at home, because this is their wish, statistics shows that they do not get the right treatment at home. For example, many of these people are just in pain and do not get adequate pain control. So this is the setup that eventually started this CMC project in London a few years ago. That's the problem that we want to solve. So the problems were mainly lack of coordination. There were many care providers for this patient, the GP, the hospice, the hospital, the community nurse, and no one knows what the other is doing. No one knows what the other was planned for the patient. For example, if the hospital doctor already knows that there is no point to send the patient again to hospital, the GP doesn't know it, and if the patient is unwell, well, this is the default, that what people do. They send the patient to hospital. And also, nobody knows what are the patient wishes. If the patient wants to die at home, sometimes the patient cannot communicate his wishes, in his last days or last weeks. So these wishes are being overlooked. So that's how CMC started. In about 2007, at the Royal Marsden, this big cancer hospital, they've noticed that there are 750 patients, end-of-life cancer patients that died in the hospital. And that was a pretty big chunk of the patients that were treated in this hospital. And this is a big cancer hospital that tried to, cure these patients. And still, almost all those that died in the hospital. So they've tried to solve this problem. And the way they did it then, this is 9 years ago, they created little care plans on a sheet of paper. And this sheet of paper included mainly two types of information. One, what the patient wants, and two, in case of crisis, what to do if the patient is in severe pain, if the patient is bleeding, if the patient has very severe breathlessness, not necessarily the right course of action is to take a patient, in this case, to hospital in end of life. So if they put this on a piece of paper and faxed this paper to all the care providers, to the hospice, to the GP, and so forth, of course, this was a very laborious process. Whenever there was a change that was introduced, because, you know, these are dynamic things. The patient could be dying for 6, 9 months, so sometimes, you know, they change their wishes, or the treatment in crisis is different. You need to update this piece of paper and to fax everyone and to make sure that they replace the old piece of paper with a new one. So this is a big, big undertaking. But even with this primitive method, the following year, instead of 750 patients dying at the hospital, only 230 patients died at the hospital, and more patients managed to die a dignified death at home, being cared properly. So a year later, 2008, the Professor Julia Riley, who is the clinical lead and the visionary for this project, went to the Department of Health with this proof and said, look, just with a piece of paper what we've managed to do. Let's now do that with a digital system. And they've created 32 pilots. London is a big city. They've divided London into 32 regions, because this is the way that the healthcare is organized in London by CCGs, and each CCG covers a region. So the Royal Marsden is actually these two blue regions, and every region tried to create its own pilot for a digital system to provide that service. You understand that this is probably not the most efficient way. And indeed, gradually in the first year, these regions started to converge. So first the two blue ones came together, then the two blue ones joined the two yellow ones, and gradually almost all of them converge into one solution for the whole of London. The reason that it made sense to have one solution for the whole of London, that eventually, regardless of who creates the care plan for the patient, what to do in case of emergency and what the patient wishes are, it's very important to understand who consumes the care plan, who are the people that read it in a time of crisis and do or not do something as per the care plan. And the main players are the ambulance services, okay? And the ambulance service is only one for the whole of London. So the ambulance service was very keen to have only one organization that will provide this information to him, rather than 32 distinct little areas trying to do that separately. So that was a big motivation for all these regions to converge into one service. And that's how CMC was born, Coordinate My Care. And in a nutshell, what CMC does, I've already said most of this. So we create a care plan. The care plan is created by multiple care providers at the same time: the GP, the consultant in the hospital, the palliative care nurse, the community nurse. They all contribute into a single copy of the care plan. Once this care plan is ready and all the components of the care plan are filled, then there is someone that looks through it, one person, normally a doctor, a clinician, and say, this is okay, press a button, and then this care plan is published. And once it's published, all these people that need to consume it, emergency services, but not just, also even the hospital itself. If the care plan was created in the hospital and the patient comes back to the hospital a month later, not necessarily is going to be looked after by the same doctors. So they can read that same care plan as providers and know what to do. In 2013, the CMC project was integrated into the NHS Pathways. What does that mean? It means that there are two services in the UK when you are in trouble. If you are really in trouble, you dial 999 and you get an ambulance immediately. But if you are not sure what to do I need to go to hospital? Do I need to go to a GP? Do I need an ambulance? Then you dial 111, and there is a health advisor that asks you all kinds of questions and then help you to decide what's the right thing to do. So in 2013, the CMC solution of digitalized care plans for end-of-life patients was integrated into this mechanism in the sense that if someone calls and this someone has a CMC care plan, immediately the person that takes the call knows about it. Immediately the call is being transferred to a clinician, which is better trained than a health advisor. The clinician can go through the care plan with the patient or the family on the phone, see if the problem is such which the solution for it is described in the care plan, and therefore he knows what to do because this has already been discussed and decided on. And if yes, deals with it through what's in the care plan. And if not, decides what to do. And decide what to do. It could be something non-urgent, or it could be something urgent. And in patients that have severe bleed, excruciating pain, or severe breathlessness, regardless of what the care plan says, always send an ambulance. Because if this patient is that severely distressed and might be dying, we always send an ambulance so there is someone with him in this difficult time, not necessarily to take him to hospital. So how did that happen? So there should be a digital system there to make it happen. In 2010, the first digital system was constructed, and it was pretty clunky and kind of a pitch, because what we've done, we've taken a social care system and we've kind of twisted it to become a care coordination system. And obviously that wasn't the most convenient and intuitive system to use for the users. It was clunky, it was not intuitive, and importantly, it was not interoperable. That means that this system could not speak with any of the other digital systems that have data for these patients and suck this data into the care plan automatically. Every piece of data on this care plan has to be manually put in. So, 2015, this is last year, November actually, which is 6 months ago, after the phase of development, CMC contracted INTERSYSTEMS, so this is my second employer, to come up with a new digital system to provide this service for CMC. And the main important bits that this system had to deliver that did not exist in the previous system were that it had to be interoperable, meaning be able to speak with other systems digitally. It had to be reliable, particularly safe for patients, so there are not any clinical incidents because the system is malfunctioning. Intuitive in the sense that if you take someone new and you give them 5 minutes training, they can start using the system easily, like you wouldn't need training for Google or Gmail or Facebook, right? So the same kind of level, and scalable because this is a pan-London service, and we want to provide end-of-life care for the patient in London. But we want to scale it in 2 ways. One, we want to scale it for the whole of the United Kingdom. And 2, we want it to be actually an urgent care plan, not just for end-of-life patients, but for patients with other chronic conditions. If I have COPD, thank you very much to my lovely assistant. So if I have other chronic disease, I have heart failure, I have COPD, I will also be in situations when there is a need for an urgent care. I've been seen by a consultant who treats me, every year. So there is already someone who knows what needs to be done. If he puts that on a piece of paper, then when I'm in trouble and the ambulance team come, they already know what to do. So it doesn't have to be end of life. We started end of life, but the intention is to scale it to other medical conditions. Okay, so now I'm going to show you just a couple of screens. I'm just checking the time. Okay. How the system looks like, de facto. So we have two different, I would call it views. One is the people that creates care plans, and one is the people that, when in trouble, they read the care plan and know what to do. So the creators, like the GPs, the hospice people, the consultants, this is the screen that they see, and it's pretty self-explanatory. So here on the left side of the screen, you can see you can create a care plan, you can view a care plan, search for a care plan, and so on, what you would expect to see. Here, this is interesting because when I log in as a user to this system, it tells me things that I need to do. For example, if I'm a senior clinician, it could be that my junior doctors created care plans that I need to approve. So when they finished and they said, this is ready for approval, it gets to me as a message on this list, and I know that I need to do that. A care plan is not something for life. It's correct for today, but next month it might need to be changed. These people, you know, these are people that the health is changing from one week to another. So each care plan needs to be reviewed once in a while. So by default, each care plan is sent to someone for review every 3 months, but I can choose, if I know the patient and I know that there is more dynamics, ask for the patient, the care plan that I've just published, to be reviewed, say, next week or in 2 weeks. So I will see it here. So I have 2 care plans that need review. These are the patients that I'm responsible for, and some of the care plans are published. Some of them are still draft. That means that me and people from my team collab together. We still are creating the care plans and so forth. So this is the screen. And for the readers, think about the ambulance team coming to see a patient in distress. They want to know quickly what's going on. They don't have time to start, you know, messing around with many menus. So this is what they see. This is the screen. So there is an urgent summary, and the urgent summary puts on one screen all the important bits that they need to know immediately, like alerts. There is a dangerous dog at home. You know, this is practical things that people need to know. Or the patient is deaf. He can't hear you. You need to, I don't know, speak loud. CPR status, whether this patient is for resuscitation or not. One of the most unpleasant things is to resuscitate patients that asked specifically, they don't want to be resuscitated. Okay? This is their wish. Or to resuscitate patients that the senior clinicians at hospital already know that there is no point resuscitating, because resuscitation will not be successful, and resuscitation is pretty traumatic procedure. And more information which is important, like what are the diagnoses of the patient, the main one, what is the treatment intent, is the patient just palliative treatment or curative, and so forth and so forth. So in this screen, they can see immediately what they need to know to do the right thing now. And if they want all the details, they can scroll down here to the patient preferences and so on. I know they, you know, in more detail, other bits of information. So this is how the system looks like. So what makes CMC different? Important to understand that CMC is not an IT solution. We, and when I say we, now I'm in INTERSYSTEMS, we provided an IT system to deliver this service, but the IT system is just a prerequisite, because even with the best IT system in the world, the service needs to do a lot more for the care planning for these patients to happen de facto. For example, training. There are tens of thousands of clinicians in London that needs now to be trained on this system. There are only, I know, 8,000 GPs alone. There are many hospitals and many consultants in the hospitals. So someone needs to train them. So we train them mainly by e-learning modules. You can't go and train one by one, face-to-face, can you? You need to provide reporting, because all these organizations that now agree to participate and use CMC, you can't force them to do that. They need to buy into it. You need to give them some feedback, how they do, how many patients are being have under the care of a CMC care plan, for how many of them the wishes of the patient were actually taken into account, and so forth. Governance is key. You need to be very careful to make sure that only the right people see the right information. Otherwise, you get into a lot of trouble with the government, with the patient, and with the media. The system has to be clinically safe, so you have to carefully analyze any problems or incidents that you had and fix quickly in order to avoid clinical safety issues. And once you have such a system, you hold a lot of data in your hand for many people, and you can start doing research on and audits on and improve the system. Now, a distinction that we make that CMC is a service and not an IT system is because the IT part is actually the easy part. Technology is a non-issue. This is not sophisticated technology, particularly with the underlying product that is being used to deliver that. I will tell you that in my last slide. The main problem is a cultural challenge. You now go to clinicians, 10,000 of them, that are used to do something in one way, and you need to make them do something completely different. And by completely different, I mean that all of a sudden, they need to work in collaboration with other clinicians, because the care plan is constructed by different clinicians at the same time. Some of these clinicians, they don't know. It's very convenient to do something with someone you've worked with for 10 years and work in the same ward as you. But if you need to do that with the GP that you've never seen and you are both contributing to the same document, it does not feel comfortable always. The patient all of a sudden can, be part of it. He can have wishes. He can say what he wants, and this has to be documented. We as clinicians, we are used to, to lead the way for the patient. We know better. We don't know better. So it's a big cultural change. And also, if you want to make a good care plan and you want to really discuss with the patient all the difficult bits and all the painful bits, do you want to be resuscitated? Who do you want us to notify? If you think that the patient doesn't have much to live, you need to tell them that in a way that they understand and can prepare themselves. This is a difficult conversation to have. And I'm sorry? I have to accelerate? Okay. Why? It's okay. I still have 15 minutes, I think. No? It's okay. It could be okay. Don't worry. Yeah. I think, yeah. In time for question, everything will become. Okay. Thank you. So this is not just an IT system, okay? If you want to have such a service running properly, it's a deep cultural change. And this is not something easy to achieve. So in the spirit of time, I will have to jump a couple of slides, but I think you got the idea. This is interesting. So now we have the system up and running in London. Do people use it? In London there are about 8 million people. About 1% of them are end of life, actually. This is the statistics. 1% of population in every country, Western country, is a dying population. So you would expect about 80,000 people in London to have a care plan. That's 1%. In de facto, we have now about 18,000 care plans, because all in all, about 28,000 care plans were created, but 12,000 people already died. So we have an active 18,000. So that's less than a quarter, I would say. And you can see how the different 32 regions that I've showed you at the beginning, how much they use the system. So you see there are regions that use it quite a lot, and there are regions that just don't use it at all. So the cultural change is not easy to achieve everywhere. If you want to have a look on the people that actually use or read the care plan, which are the urgent services, you can see that it's mainly being read by the 111 provider. These are the people that answer the phone for people that need advice. The ambulance trust, a bit less, and the out-of-hour GPs, a bit less. You have to remember that in the UK, 2/3 of the time, it's out of hours. it's emergency. Only 1/3 of the time you can actually go and see someone that you know. But we already see signs of success, because if in the whole of England, the number of patients on average that are in hospital is 54%, for people that have a CMC care plan, this number is 19%. And these patients now can die more at home, at a care home, or at a hospice. You can see PPD is the preferred place of death. That's where the patient wants to die. You can see that for 76 of the patients, we achieve the preferred place of death for the patient, either the first one or the second one. If you want to understand the type of patients that we have, this is the main diagnosis of the care plan. So because it was originated in the cancer hospital, about half of the patients, the main diagnosis of the reason that they die is cancer. But we have many patients already that have a different main diagnosis. For example, dementia. We know that about 1/3 of the people above the age of 60 will die of dementia in the UK, in the Western world. The people that normally are best to create the care plans, are most willing to cooperate, are the people in hospices. So most of the care plans are originated in hospices, then acute trust, then by GPs. And de facto, we see that people that have a CMC care plan are less likely to need an ambulance when they call 111, 50% less likely, and more importantly, they are 80% less likely to be taken to the emergency department when they call 111. So this is a big differentiator for them. And of course, this has money implication for the system. I don't know how is it in France, but in England, the NHS is very tight with money. And this is a big saving, because each of these patients being treated with unnecessary treatments in hospital costs the system more than £2,000. And if you do the math, you see you get quickly to many, many millions of pounds which are being saved. The main barrier, of course, is people to make it happen, because as I said, this is a culture change, and people are intimidated by the change. They are being replaced by a new system. They need to start working collaboratively. The patient gets more power, so this is a slow change that we are slowly overturning and succeeding to make. And the best way to achieve that is with training. When you train the people properly and you make them really understand, these are good people, all these care providers, when you make them really understand the benefits for the patients, and particularly when you audit the data and you show, not just by theory, by your results, the benefits for the patients, that's the best way to deliver your message and make them come with you and join you on your journey. Now, with all the will in the world, if we are going just to rely on clinicians to adopt this system, it's going to be very tough. And what we're going to do, and this is what we're doing in a moment, we are going to open the system to the patients. So we are now creating a patient portal that all the patients that already have a care plan will be able to log in and look at their care plan, at least read it. Currently, they don't see it. It's only for the ambulance and the doctors. Still, the patient is outside. We said we want the patient in the middle. So we are now creating, and in a few months, every CMC patient will be able to log in, or the family, and see the care plan. But more importantly, what we are going to do next year, a patient will be able to start a care plan. So I will be able to go on CMC website. You know, maybe I have some wishes for my own death, hopefully in many years, but I already know what I want. I will be able to go, start a care plan, put what I want and what I wish for, then go to my GP. My GP will ask me more questions, and he will publish the care plan. Because the care plan, as I said, is not just for end of life. It's also for acute diagnosis or acute care. And this is the way it will look like. So we will ask a question about his health. Is he fit and well? Does he have a long-term medical conditions? Is he terminally ill? And based on his answers, we'll direct him in the right path to create the appropriate care plan for him. And another thing that we are doing is that we are, of course, making it all mobile, because patients will not go now on a desktop or a laptop to start a care plan. They will look for the app to do that. So we are also creating the app to the CMC for people, the ordinary people, to be able to start a care plan and to initiate the process. The GPs, the care providers will follow. So the future, I'm finishing, so I'm okay with time. Okay. So the future, we want the patients to be in control. We want to respect the wishes, not to overlook the wishes. We want to avoid all the unnecessary admissions, which are expensive, which are distressing for the patients and have no purpose. And we want to maintain the dignity of our patients. I just want to conclude with my last slide and to say, I've shown you CMC from the clinician and the patient perspective, what are the benefits. But this is all happening because the reason we can create CMC is a product or a suite of products called healthcare by INTERSYSTEMS. And healthcare is like a Lego. If you know Lego, you can take different pieces and you can build whatever you want from the pieces. So healthcare is like a Lego. There are different components or modules, and you decide which one you want to use, and based on what you use and how you build them, you create a system for your own needs. So a main piece of the Lego is something we call the information exchange. This is a piece of technology which is capable to speak with whatever systems you have in your health economy, because it speaks on all the IT languages for all the systems, and create per patient an integrated care record, a one record for this patient on the fly in real time for these patients. So every health solution, including CMC, normally has this piece in the center. There are other pieces like the patient index. For example, some countries have per patient a very unique identifier. So if I have data on 50 systems, with this identifier, it's very easy to get my data from all systems, but in some countries it's really bad. There is no identifier, and you need to play some tricks to find out my data on the different systems. For example, with demographic data, like my address, date of birth, and so forth. But this is not accurate science. Sometimes you need to make a judgment. So there is a module that does it called patient index. I will skip that. Care community is actually the piece of Lego or the module that allows care planning and care plans, and CMC is the first use of that module. Personal community is the modules that allows patients to see their own clinical record, and I've told you that we are going to use it for CMC. And maybe the other last one that I will mention is the active health repository. All kinds of strange names, I know, but I think the principle is important. Once you hold in your head the integrated care record for a patient, but not just for one patient, for all the million patients under your care, then you can take a step back, and then you can see the screen, and you can ask questions about your population. You can ask, who are the most diabetes patients in my care which are unmanaged properly, with a hemoglobin A1C is above 10, which has 5 chronic conditions, and they have no spouse. You can start asking the questions because you hold this information for everyone, not just for a single patient. So, thank you much for your attention. Thank you very much for the invitation.